Okay, thanks everyone for joining us again for Discussions in Diagnosis. We took a little break for a couple of weeks due to travel schedules and other conflicts, but it's my sincerest pleasure to welcome Dr. Amy Zhang, who's joining us this morning. Dr. Zhang is an associate professor both in the Department of Urology and at the Francis Bolton School of Nursing. I think we stumbled upon each other's work for some other reason, but we're going to talk about some of your research today, especially in terms of diagnosis of depression. So thanks for joining us this morning. So I wanted to start by asking you some basic questions, Amy. So your current research focus is on irritability, inflammatory biomarkers, and diagnosis of depression. So three very different variables. Can you give us an idea of how you think we are doing overall in terms of diagnosis of depression? And how did you stumble upon the connection among those three variables?
So I think in terms of a diagnosis and the treatment of a depression, we all know that depression is really hard to treat. There are many different treatments, but the effect size of this treatment is still pretty modest at this point. So the challenge will be how we are able to identify depression early when it becomes so obvious, so it's more treatable. That's the things I have in mind. So the reason I come down to the correlation among these three variables is because I have been working with people who have cancer. What triggered my initial interest is to see what are the racial differences, because the literature has indicated that African Americans tend to report depressive symptoms very differently from white American when they all have cancer, even if when they don't have cancer. So I started with cancer population to understand what made this racial difference so significant. So what I found was interesting. We compared the depressed versus not depressed African American. Also compare the depressed African American with depressed white cancer patients. So these are all patients have cancers. So these are in-depth interviews, and also add on that is the standard questionnaire assessment. So what we found was one is very consistent with the literature is depressed African American report more physical symptoms than non-depressed African American and the depressed white cancer patients. On the other hand, they reported less sadness. So if we think of sadness as one of the main symptoms, core symptoms of depressive symptoms, right? We did say both are depressed, both racial group are depressed, but the African American reported less sadness there. So what was the other differences? One of the things we unraveled was African American, when they are depressed, they reported more irritability verbally to us. And there's no questionnaire to capture that. So primarily it's from interview. And then we try to understand why they are so different from the other two groups in terms of reporting irritability. So we didn't see any demographic or any medical variable, any differences in that area. They were all pretty similar. The only thing we could say is that African-American cancer patients were sicker. They have more multiple comorbidities. So then that raises the question is whether or not that irritability is actually correlated with the underlying medical condition. For instance, if they have a more disease, could they be experiencing more inflammation, right? So this is where the inflammatory biomarkers, irritability, mood state, and the depressive symptoms come together. So based on that first initial finding, that was like a decade ago, I developed, along with my colleague, Dr. Stephen Ganassi, who just recently passed away this year. So we developed a measure for irritability alone, but this is a measure was for cancer patients. So we retested this measure along with a couple of other colleagues like Dr. Awusu, Dr. Gao from psychiatry in cancer population, in the breast cancer patients. So what we found was once the measure really did well in terms of all the psychometric properties, the other finding was that we did measure 3 biomarkers. That's L6, HS, high sensitivity, HSP. I forgot the name. Excuse me. So just okay. I can check.
That's okay.
Yeah. So we found this 3 marker and the BDNF, right? 3 markers. We found the correlation between HS. Again, I apologize. I have to find out this biomarker name. This is like a critical moment. It's the most critical variables slip my mind. It's really interesting. Give me one moment. It's a very common name. So it's a reactive some kind of HS sensitivity. Can you help me there?
It's not IL-6, is it? No.
IL-6, there's another one, very
Okay.
commonly used in cardiovascular population.
We'll stumble upon it eventually.
Yeah. So this biomarker, actually, I forgot the name, is a very, I use it all the time. Anyway, so it turned out to be correlated with irritability before they gave the chemotherapy to cancer patients. So when the breast cancer patients just newly recruited, we tested them as a baseline. There was only correlation between these biomarkers and the irritability. And there was no correlation between any other biomarkers with any depressive measure, whether it's a severity of a depression or the diagnosable depression cases, right? There's a variable for that. There was no such correlation. We only observed a correlation between irritability and the biomarker. And 3 months later, after the chemotherapy, which presumably increased the inflammation, right? It's very well known that a treatment will increase the inflammation. Then what we observed is that irritability and the biomarkers, both L6 and the HSCRP, predicted the severity of depression and also new onset of depressive cases. So irritability is independently predicting, and the biomarkers are independently predicting. We were not able to test if there's interaction because our sample is really small, it's only 48 people. But we see that over time, they both predicted the depressive symptoms and the new onset, as well as there was a correlation as a baseline. So what that suggests was that irritability was correlated with underlying inflammation better than the depressive symptoms. And also both predict the new onset of depression over the increase of inflammation within the patients for the 3 months chemotherapy. So those are the basic insight we have. And then we also tested the irritability measure we have in multiple occasions, both domestically and internationally. And the results are pretty consistent at this point. Is the measure doing well in terms of psychometric properties? And we also have an indication this is correlated with underlying inflammation system, inflammation biomarkers. So what does that mean? So that has a really interesting implication. That is, first, we know that within the medically ill population, it's very difficult to differentiate what the symptoms are due to the medical disease, for instance, cancer, or what are symptoms are due to the depressive symptoms, right? Patients have a secondary reaction, for instance, to their underlying disease, whether it's diabetes or cancer. And is that depression or is that their original disease, right? The outcome of that. So if we can assess, if we can identify there is developmental process, which is as a disease get worse, the irritability mood maybe get worse potentially lead to depressive symptoms, could there be this possibility underlying, they have a joint underlying disease process? If we can capture irritability, that will help us to identify people who are at risk to develop depression. And if we can capture them early, it will be easier to treat because we know there's a multiple treatment options, even including some of the yoga, some of the behavior, lifestyle options that can reduce the mood, which is a feeling, people feel irritable. So this is where we're at in terms of
that is absolutely fascinating because I'm very curious about irritability in general, how it's defined, because we know that culture and even maybe gender influences depression. I'll ask my older male patients, "Do you feel depressed?" And usually it's, "Oh, I'm fine." It's not a meaningful response. And I know in different cultures, depression is perceived differently, and our questions are very, I think, Anglo-Saxon. Have you lost interest in your usual activities? I mean, a lot of people aren't able to answer that. But the irritability issue, I think, is really interesting, and you have some scales for it. But can you give us a little bit more insight into how you define irritability?
Definitely. So first, let's see how it's defined before us, right? In the literature, the irritability, the literature has suggested people have recognized first, irritability is a mood state. It's a feeling irritable. Secondly, the literature has suggested that it is different from either anger or anxiety, right? So the anger is more about a feeling towards a particular subject or object, but the irritability appear to be more spontaneous. And the anxiety appear to be more more stable and more about showing in behavior avoidance due to a fear, right? But the irritability appear to be more transitional, less stable, but also it's more about the reactive. So those are the things we know from literature already, that there are subtle differences among this different kind of a mood. On the other, also the literature has indicated our investigation for irritability is primarily among the children population. And we know very little about adults. Basically, there's other than some cross-sectional survey data, we know really little. We only know irritability was correlated with depressive symptoms, but we don't know how they correlate, what's the nature, what's the scope of this association. So in our data, what happened is we looked into patients' narrative among these 75 people. If they talk about irritability, what do they mean, right? So we found that they really talked about irritability in 3 different ways. One of the things that really stand out is when they talked about irritability, oftentimes they were talking about their physical feelings, not necessarily about the feeling towards something or at the moment or mood. For example, they would say, "I did not sleep and I was feeling really irritable," or "I feel irritable because my body or something feel irritable because I couldn't sleep for the last several nights," or "the pain make me really crappy. I'm really irritable because of that." So there's a close relation between the physical feeling and that reflection upon that physical symptoms. And this has not been reported in the past. The second one is pretty well known, is the mood. They would describe how they feel, what the irritability mean. Primarily is like everything can get on my nerves, right? The third one we also found was a behavior dimension. Now the pre-existing literature indicated a little bit, but we found a very clear indication that when people feel irritable, they were clearly saying, "I'm short on others. I cannot stand others. Leave me alone," right? So there are 2 different kind of behaviors, subtly different. One is feel reactive towards something, cannot control that irritability and snap at other people. Another one is because they feel they can upset others, they try to leave other people alone, try not to be bothered. So that component currently is in our scale, but it's something we still need to test out. If that's a transitional into depression, how is that closely related to irritability? But these are the 3 dimensions we define in physical, mood, and the behavior ways of exhibiting this symptom.
That's really fascinating. So you are planning a cohort study to look into the neuroimmunological mechanisms for development of depression among those with chronic illnesses and, whatever it happens to be. So can you tell us a bit more about that?
Yeah, so we want right now, given the scales we have tested in multiple populations, we know the scale works. It can capture the phenomenon of irritability. The issue is how this irritability mood is different from a depression. In what way, at what point they're associated, in what way, right? So one of the challenge would be, what is the underlying process? What is neuroimmunological process? So our biomarkers are primarily inflammatory biomarker. So, and it's very limited to, two biomarkers. So my collaborator, Dr. Alan Levine, would suggest saying, let's look into the entire blood system. Let's use RNA sequencing to see what are some of these things going on in the whole blood, in the peripheral blood system, how that is elevated during the irritability process. So we can identify the scope and the specific, probably more biomarkers that are associated with irritability. So with that approach, we may be able to actually identify what are some real biological substrate of this or mediator of irritability mood state. So another challenge question is, there's a concept of study about neuroimmunological pathways of depression. There has been a number of promising biomarkers for depression, which mediate depressive symptoms. We could look into some of those to see how they are correlated with immunological inflammatory biomarkers. So those are the things. We also have specific techniques to do that. If we find immunological biomarkers, we could use certain things like an enhanced flow matrix or something like that to match that with the neurological biomarker to see how they work together, how they trigger each other, or how they relate to each other during the process as we observe a patient experience irritability as well as depressive symptoms. So that's our goal.
That's the pathway. So the next question I had for you is, I think, and I see a number of my partners in practice, Dr. Kowalik, for example, who's on the line right now. And I think it's fair to say that all of my patients have a chronic illness. Even the children have asthma for the most part, or they have some other illness, or at least 90% of them do. And irritability seems to be a very, very useful tool, a very useful variable to assess, not only because it predicts depression, but maybe physical symptoms as well. Can you see us assessing this in a clinical context, and how might we do that? Definitely.
So I'm thinking in two ways, right? One is the questionnaire we created called TSI right now, is the irritability scale initial version. We would like to use a larger population, larger sample to finalize some kind of a cutoff to differentiate the irritability at which appear to be normal, right? Come and go because of what's going on in life, but also a more stabilized state of irritability where people cannot get out of that state. They just experience it on a daily basis. And there has been literature indicating irritability can actually affect the function, can actually affect other aspect of life, right? Can interrupt with people's daily routine. So that does have a detrimental effect. So therefore needed to be treated if depression, if irritability get into that chronic state. So one of the things we need to identify cutoff scores for clinician to understand at what point irritability become more disruptive to patient's life. So at that point, maybe they can recommend certain things for patient to be more aware of how to self-manage those symptoms. So another thing is if we could use the biomarker data to indicate how the irritability relate to depression, there is a potential we can use some laboratory values to give a cutoff score on the irritability to see at what point patient actually is already in the moderate depression or in the severe depression, even though they don't exhibit that verbally or in certain behavior, you cannot see it. But in irritability, they are more willing to report for medically ill population. So in that case, they could use that value, both clinical and the lab-based cutoffs, to decide that this patient needs to be screened for depression or take action early to treat that mood state.
Yeah, that's absolutely fascinating. So I think that what you're saying, Amy, is irritability may be a precursor for depression, but it also may be a surrogate measurement, and it's easier. There's probably less stigma. I can think of patients who say, "Oh, I'm irritable," but they're not going to likely to admit to depressive symptoms. So, so there's a question from Dr. Kowalik that just came up, which I was wondering about as well. And you know, we have standardized tools for measuring depression, PHQ-9. We have basically even simpler screens than that. And I noticed in some of your work there are some screening tools, irritability scales, etc. Is there something practical that we can use to measure things, or is it just a matter of asking the patient?
So the standard tool, we have PSI, as I mentioned, we develop a questionnaire. This questionnaire is still long, has 35 items. So if we can get funding, we can shrink that into fewer items, and we can identify cutoff scores so clinicians can use that. At this point, for using our tool, there is no cutoff. So you cannot really relate irritability with depression, but you can still see if you use that to measure patient over time, you can still see how that go up and down. You can measure the level, the severity of irritability. That is one thing. There are other multiple existing irritability measures out there, but I have to say they are very different. One of the limitation is most of them measure irritability as a unidimensional mood effect, mood state. So they only ask about how they feel, rather than ask about the physical aspect or behavior aspect. And therefore, they're limited to they're sensitive to certain kind of irritability, but may not be very sensitive to early onset or late severe irritability. So that's one thing. Another thing is, some of the older measures they're using are mixed a measure of mixed emotions, such as irritability along with anger or irritability along with anxiety together. So it's really hard to tell which one is what. So another thing is some of the measure from NIH was really about children. So it's not necessarily relevant to adults. So those are some limitations for the existing standardized irritability measure. Now, there has not been a good test about how irritability relate to depression. Therefore, using depressive symptoms scale would not apply to irritability.
Right. Understood that. So we're going to throw it out to some questions. There's quite a few questions actually on the chat. I'm just going to, and I know it was a fascinating discussion, Amy, but we'll try to get through as many of the questions as we can. So first of all, Dr. Saeed is concern is that so many of our patients in primary care especially are already on medications of all sorts, anti-inflammatory medications. Does that sort of confound some of the measures, the biomarkers you're describing?
Yeah, so yes, they could, especially if they use certain drugs versus other, right? Different drug has a different effect probably. So what we usually do is this is something we cannot stop a patient medication. We cannot just create a vacuum to watch people who don't use drug, but purely for our observation, we don't really have that good opportunity. So what we do is methodologically, we try to observe people as they are using drug at same basis. We try to observe them multiple times along the line. So use them as their own control to say, okay, given the medication you're taking today, this is where you're at. Now, if you're given if your inflammation go up, whether it's caused by drug or by anything else, how that influence your mood. Now, how that, so in terms of clinical observation, in other ways, we could use patients in their own control to do away that concern. But in terms of RNA sequencing analysis, personally, I'm not expert in that area. I do know my co-investigators, they are experts in that area. They only ask for people who do not use certain drugs to be participating. Mm-hmm. They're not a drug abuse or dependency. They don't have that diagnosis. Those people will be excluded, but they're not concerned about people who are using other drugs to be in the, like anti-inflammatory drugs to be in the study. So I guess that may have something to do with how the RNA analysis was being carried out. They probably own the paper. Yeah.
All right. Dr. Welton has an interesting question as well. And he's asking, are you thinking of irritability as the equivalent of sadness for social and cultural reasons, or is it a distinct phenomenon? And are you seeing depression as a heterogeneous collection of similar diseases? And some people have a sadness predominant depression, whereas others have a irritability predominant.
Right. So definitely, we all know depression is heterogeneous, right? It can be due to many different causes. It can have many different manifestations, and it can be that manifestation can be affected by how people feel, how the environment, what the environment is or culture is. So the issue is whether irritability is distinct from depression. That is the challenge we're handling, right? Mm-hmm. So we want to differentiate them, use the medical technology we know of today to identify if these two phenomena we know they're correlated, especially in people who experience depression. We want to know that correlation, how they correlated, what's the nature of that correlation over time. What are the cause, for example, the underlying the underlying biological pathways, and how we'll be able to differentiate that social issue. So that's where we're at. Now, just based on the clinical phenomena that I haven't seen, my personal belief is irritability is a distinct mood state. Like anxiety, anger, they are not necessarily depressive. Example will be anxiety and depression come hand in hand, but they're different. The issue is we don't know why they're different, or how they're different, and that's where we're at.
Great, thank you. We are just about out of time. I'm just going to see if there's one possible additional question from anyone before we wrap up. Let me scroll through here. No, I think we're great. Thank you, Dr. Zhang. Fascinating discussion this morning. And if there's any additional questions, I'll forward them to you as well. So thanks for joining us this morning. Thanks, everyone.
Thank you for your questions. Really appreciate it. And thank you for coming.
Thank you.
All right.